What you're going to see in the course of these lectures is the neurologists and neurosurgeons and psychiatrists are going to come in and they're going to show you pictures of a lot of brain scans for sure, and you've already seen some already, but you'll also see EEG recordings perhaps and so on. And it's really important that you know what these techniques are all about. So what I'm going to do is to run through a whole bunch of the major techniques, and there's a lot of these. So today we're going to cover actually quite a lot of ground, so hold on to your seats because you'll probably be here for the whole 80 minutes. There's quite a lot of material, but I've tried to organise it in a sort of logical way that makes sense, and I hope you'll get insight into what these techniques are. And you've heard of many of them already, like MRI and EEG and CAT scanning and these sorts of things. But what I'm going to do is just to describe these in a little bit more detail so you get a good sense of what they're all about, and also when they're used. And the other thing to know about techniques, and this is important, is what they cannot do. What are the disadvantages, and not so much disadvantages, limitations for different techniques. And so that's as important as knowing what they can do. So let's get going on this. And the first is just a table or a listing of the sort of common techniques that are used in the clinic. People like Francois would use these in his practice. And there's quite a lot. You don't necessarily use all these techniques on a single patient. You obviously have to make judgment calls as a clinician to figure out what techniques you're going to use. But anyway, one of the first things that neurologists do, of course, is a clinical examination. The patient comes to them in the clinic, they've got a headache, or they're dizzy, or they've got numbness in their fingers, something like this. Well, the first thing the clinician will do a very thorough history. When did it start? How serious is it? Does it come and go? All these sorts of questions. And they'll measure things like reflexes, how well they walk perhaps, what sensations they get from touching, and so on. Can they see properly? All that type of general sort of examination. They may or may not go on to do biopsies, depending on what they suspect is going on. And you can do biopsies of nerve and muscle. That is, you take out a little chunk of nerve or a little chunk of muscle and put it under the microscope and see what it looks like. And is it normal, abnormal? These are the sort of questions. You can also take fluid from the spinal column, so-called cerebrospinal fluid. It's called a lumbar puncture. And often the metabolites that you find in the cerebrospinal fluid might indicate a disease, for example, meningitis, for example. You might get bacteria in the fluid, and it could be meningitis. One of the really important things, or common things, I should say, that clinicians often do is brain scanning of one sort or another. And there's a bunch of these, and I'll go through these later on in more detail. CAT scanning, SPECT, magnetic resonance imaging, and angiography. We'll talk about those later on. You can also do electrical recording from subjects. You can do electromyography. That's where you actually record the electrical signals in the muscles. So you just put a couple of electrodes on top of muscles, and when the patient makes a movement, using that muscle, you'll see electrical activity. And that can sometimes give you a clue to what's going on with the patient. And electroencephalography is another EEG. These are electrical recordings from the scalp. And we'll talk about these, I'll give you examples later on. And electrical stimulation is another technique that's used. You can either stimulate nerves, and for some conditions, you can actually implant stimulating electrodes deep inside the brain and stimulate structures in the brain. And you'll hear a lecture on that. It's used for helping some people with Parkinson's disease with great effectiveness. And that's called deep brain stimulation. So that's just a sort of list of what some of the techniques that neurologists might use. Now, psychiatry is a little, oh, big pardon. This picture is from the Neuroscience at a Glance, and a few of you have asked me what book should you buy, if any. Well, if you're going to buy any book, I suggest you buy this. I looked it up on Amazon. You can get it from Amazon Canada. It costs about $40, and it comes within a couple of days. It's a very nice book, and I would recommend, again, if you're serious about neuroscience and neurology and so on, to get this book. It's a great reference. Anyway, this is just one of the figures from that book, and it basically summarizes what I've just told you in the previous listing. So here's the sort of blood test that can be done from a lumbar puncture. They just put a needle into this space in the spinal column, suck up fluid. They've got listed up a history and examination is here, scanning and imaging techniques that can be done, electrical stimulation recording to measure nerve conduction velocities and so on. So more or less everything I've told you listed on the first slide is shown in this more pictorial. Now, psychiatric disorders, now these are the problems with mental functions and mind, so to speak. The psychiatrists, they spend much more time doing these psychological tests. And there's a huge number of these tests now for different aspects of personality and so on. You can do intelligence tests, personality tests, tests for aggression, all sorts of things. There's many of these things. And here's just a few of them. So just note in your notes that this is just a very short, brief listing. There's many, many more. But not all people who go to psychiatrists initially actually have a psychological illness. Some of them might have a physical illness. Something might be wrong with their brain. They might be growing a tumour in their brain that's giving them problems with depression or something like that. And so very often the psychiatrists have to rule out physical problems with the individuals, and so they can do laboratory tests along the way that I just told you before, or they can do brain imaging. So sometimes psychiatrists go to these techniques, and depending on what they find, they'll either continue with the patient or they might transfer the patient to a neurologist or a neurosurgeon or something like that, depending on what the situation is. And remember I told you that clinical neuroscience is really the coming together of three different fields: neurology, psychiatry, and basic neuroscience. And in basic neuroscience, what we're trying to discover are how the brain works and how it can be fixed. And many of the techniques that are used in basic neuroscience are very expensive and very limited in how available they are. And so they can only be used for sort of very basic research purposes. They're just too expensive to have in every hospital and things like this. So here's some of the techniques that are used for studying normal brain function. And what I put an asterisk on here, these are the ones that are currently not in widespread use, in either neurology or psychiatry. Brain lesioning and inactivation is used a lot in animal research and some human research. Neurosurgeons might, for example, cut part of the brain out or cut a fibre tract or something to try and help the person, and then you can study the person after that in basic research studies. Sometimes you can inactivate part of the brain, and I'll tell you a technique for doing that. It's with magnetic stimulation. You can inactivate part of the brain with magnetic stimulation. Brain scanning, functional magnetic resonance imaging, although it's quite common for research, it's not done very much in clinical practice. Positron emission tomography is not done that much, but it's being done increasingly, and I'll talk more about that later. And then this DTI, I'll again talk about this. These are sort of high-level, very expensive scanning techniques. And then there are recording techniques, the two that I've already mentioned, and there's a couple of other ones that are specialised for research. Magnetoencephalography, this is measuring very tiny magnetic fields in the brain. And the piece of equipment that does that is enormously expensive, and as far as I know, there's only two in Canada that can do that. But it again gives you very important information about how the brain works. And another very powerful technique in basic neuroscience is to use single unit recording. This is where we put a very fine microelectrode just outside a nerve cell and record the electrical activity in the brain during normal behaviour. And so we can collect information about how single nerve cells work during behaviour. And then we can electrically stimulate with electric, or we can magnetically stimulate. There's ways of magnetically stimulating the brain, and I'll describe that in detail. So that's starting off with just listings of these things. So what I want to do now is to talk about many of these things in more detail, just to flush the whole thing out a little bit more. So we'll start off by examining brain damage. And there are three basic ways you can do this. You can do post-mortem examination, or you can do CT scanning, which is very common, or you can use magnetic resonance imaging, so-called MRI. Now, post-mortem, you've already heard about Phineas Gage from Peter Nguyen a while ago. Now, this wasn't really a post-mortem. What we found out where we know the injury was in Phineas Gage's brain was not from post-mortem. They didn't collect his brain after he died. The way they actually figured out exactly which part of his brain was damaged was doing this computer reconstruction just a few years ago, in 1994. So they had the skull of Phineas Gage, and they knew where this bar, this huge bar, went up through his cheek here and out through his skull. And by sort of figuring out where the brain is located in the skull, they can then work backwards and figure out, this thing went right up through his frontal lobe. And so we knew from descriptions of Phineas Gage how his behaviour got changed as he became far less serious and so on. And then now we know that it was this part of his brain that was damaged. So that's a sort of a funny sort of post-mortem examination. But one I've already told you about, another, this is going over a little bit before, this is Tan's brain that Broca analysed way back. And this was this big damage here in the frontal lobe on the left side that really strongly influenced Tan's ability to speak. And so this is one of the first examples of using sort of this post-mortem examination of brains to localise function within the brain. And this is now, this region here is now called Broca's region in the frontal lobe. Now, we are still doing analysis of brains after death, and one of the ones that's quite noticeable because it's been used quite a lot lately, some of you may be aware of this, is what's called chronic traumatic encephalopathy. And this is caused by repeated damage of the brain in violent sports, generally speaking. And what happens here is that there's an accumulation of what's called a tau protein in the cortex. And they've done post-mortem studies on quite a number of athletes now, football players, and more recently there was one done on a hockey enforcer, I've forgotten his name, who died at a fairly young age. And there's a group in Massachusetts that's collecting the brain of these football players and hockey players and so on that die at a young age or have serious difficulties, mental problems, maybe depression and so on. And what they've found in almost every one of these cases is this accumulation of the tau protein. So the general idea is that the sort of dementia and depression that's caused in these individuals is due to the accumulation of this tau protein that's then influencing the functioning of the nerve cells in the brain. And of course, Muhammad Ali here, he's probably got this. He's not dead yet, but just had his 70th birthday, I think yesterday, wasn't it? And he's probably got it. Certainly a lot of boxers must have it, and I imagine this is going to go up even more so with this crazy sport that's becoming very popular now. But football's another one. You may have heard that there's a class action suit going on right now by a whole bunch of NFL players in the United States suing the NFL league because they figure their difficulties in functioning, day-to-day functioning, has been due to traumatic head injuries in their sport. And so, the NFL is now in a quandary what to do about this and how to modify their rules so they don't whack their heads together and so on. But anyway, this is just an example of where sort of a post-mortem examination can give you information about what's going on. And we can't actually look at this with scanning techniques now. As far as I know, there's no way of sort of looking at people right now and say, well, they're still alive, and saying, oh yeah, they've got accumulation of tau protein in their brain, but that may come along in the near future. Just, if anybody's got questions, just shove up your hand and try and answer them as best I can. Okay, so let's move on. Let's go to these imaging methods. Now these are things you should know about in great detail because they're used so commonly in neurology and research. Computer axial tomography or CAT scanning or CT scanning. This is probably the most common type technique that's used in hospitals. It's relatively cheap and it can give you quick information. MRI, I'm going to talk about more of these. This is just the list, and then we'll go through each one in more detail. DTI is another one, fMRI, PET scanning, and angiography. So that's just the list. Now let's look at each one of these individually and talk a bit more detail about each of them. Computer axial tomography. This is the contraption, and it's in many hospitals all over the place, very common technique. And individuals, let's say you have a stroke. Almost the first thing that they do when you take you to emergency, or your relative, or friend, whatever, would be to put you in one of these machines and see if there's evidence of a stroke. And if there is, then they'll begin treatment immediately. So CAT scanning is common. It's called tomography because the way you create these cross-sectional images of the brain is shown on the right here. is by doing slices with X-rays. So the X-ray field sort of slices through the brain, you collect a whole bunch of images, and then there's all sorts of computer algorithms that will then generate the images that the neurologist would look at. And it's relatively cheap and it's fast. So that's CAT scanning. Magnetic resonance imaging. This you've already seen some pictures. I know Peter showed you a few, and you'll be seeing a lot more over the next couple of months. I can tell you that. And this is the contraption. As many of you might have had MRIs, let's say for a knee or a shoulder or something like that. It's done for more than just brains. It can be done for any part of the body, and it's a beautiful technique for showing you the sort of internal structure of the body. It could be the liver or the heart or whatever. In this case, it's the brain. So there's a colossal magnet, very, very powerful magnet, and it involves feeding in radio signals through a special coil that's around the part of the body that's going to be looked at, and there's got to be a detector to detect signals that are generated by this radio frequency coil. And these are fairly common. They're in most hospitals, big hospitals, and there's certainly a whole bunch of them in this hospital. Underneath the emergency department here, there's about 4 or 5 of them, I think. So if you need an MRI, I think that's where you're taken to in this hospital. And I think some of the private radiology groups have these machines as well these days. So that's MRI, and it gives you these unprecedented clear images of living brains. You can look at a living brain. Any of you could have a scan of your brain right now by going in. And this is what it would look like. So here's just a drawing of a brain. And again, I think Peter showed you a picture very similar to this in his lecture early on. And here's an MRI scan going through a circular section, straight through the middle of the brain. And you can see all the corresponding structures. And as I said, this would be a living brain. Now let's say that this was an injured living brain, then you might see a big white patch up here, or a big dark patch, or something wrong with it. So you can see injury. You can see injuries very easily with this technique in really clear detail. That's one of the nice things about MRI. Its spatial resolution is much higher than CAT scanning. You can see things much higher than with CAT scanning. And here's just an example of comparing MRIs in a normal brain and an Alzheimer brain. Alzheimer is a problem with dementia. You lose all sorts of cognitive capacity, most notably memory, but there are other aspects of cognition that go as well. And initially, a very prominent problem is there's a degeneration and malfunction of cells in a place called the hippocampus, which is down here. And this is a normal brain, the hippocampus outlined in red, and you can see in the Alzheimer's brain it's shrunken, and there's a big space here. And you can also see in the Alzheimer's brain that there's general shrinkage of the whole brain. The ventricles, these are the ventricles here, much bigger, and you see these bigger spaces in the sulci of the brain. So that's the sort of thing that you can get. And again, you're going to see tons and tons of these images as we go along in this course. Now, one of the most spectacular new techniques coming out is called diffusion tensor imaging. This is not done clinically. This is a sort of research tool, but you should know about it because you're going to, over the next few years, there's going to be many, many more of these published. And what this technique, it's a sort of modification of the MRI technique, but this is to show up specifically myelinated fiber tracts, nerve tracts within the nervous system. and what it does, it monitors the movement of protons along axons, basically, protons in water molecules along fiber tracts. And then with a whole bunch of computing and analysis, personally I don't know the technique exactly, a long shot, but this is the result of it all, is that you get these really spectacular images of the fiber tracts, and these are sort of artificially coloured, of course, for the different tracts going across the corpus callosum here. And what this enables you to do is to examine the fiber tracts in patients, for example, and compare to normals, or you could study, let's say, the normal change in the fiber tracts with aging. So as we grow older, the brain changes, and the question is, well, what exactly is changing and how fast and things like this. Well, with this technique, you could ask the question, well, does this big tract represented by blue here, is that modified with aging? In other words, as you get older and you're more forgetful and so on and so on, this fibre tract change and so on. As I say, it's not being used clinically yet, but I think it's just a matter of time before it will be. But you should be aware of this technique because it's going to be a very powerful one. And what we know is there's been a lot of studies, sort of cross-section studies involving many, many people that have shown that certain cognitive functions are related to differences in these fibre tracts. So impulsive person might, for example, have more of one, a greater density in one tract than a shy, retiring person. So this is the sort of test they do. They have two personality types, put them in the machine, make a comparison, and then they start seeing differences in these fibre tracts. So one of the ideas is that cognitive function and personality depends to a certain extent on how the brain is wired up with these fibre tracts. So tons of stuff to do using this technique. Now this is a very important technique from a research point of view. It's called functional magnetic resonance imaging. Functional, stress the function. Because what this allows you to do is to determine which parts of the brain are more active when a subject is doing a certain function. Let's say speaking, or looking at something, or listening to something, or memorizing something. So you can isolate the function, and while the person's doing that, you look into the brain and you can see which parts of the brain are more active than normal. And the way this works basically is that the MRI, the signals that it gets, depends on the ratio of deoxyhemoglobin to oxyhemoglobin. And these sort of orange dots here is meant to represent the neurons, and this is in the unstimulated tissue. And when the neurons become active, stimulated, so now they turn to sort of red, there's an increase in the ratio of oxyhemoglobin to deoxyhemoglobin. So you get more of the more oxygenated hemoglobin. And that changes the signals that you get out of the MRI machine. And again, with a lot of very sophisticated computing technology and so on, we're able to detect where those changes occur, and you can localize where there's been a change in blood flow. So basically, fMRI is not measuring, get this straight, it's not measuring directly the activity of nerve cells. It's measuring indirectly the activity by the changes in blood flow around the active neurons. So really, in fMRI, you're measuring blood flow changes, but those blood flow changes are produced by neuronal activity. Anyway, this is just an example, and the signal you get from this is often called the bold signal. And the bold signal stands for blood oxygen level dependent. So that makes sense because when things become active, you get more oxyhemoglobin. And this is just one example. This is the back of the brain here, and you know from Peter's lecture, this is where the visual cortex is, right at the back of the brain. And this was the activation of the visual cortex by visual stimulus. So you use this technique then for localizing functionally active regions of the brain. And again, this can be done in normal individuals. Any of us could go, today, we could go into the machine across the way here and have an fMRI and do that in relation to a certain task. And it's okay. Still carrying on with the imaging techniques. Another one is positron emission tomography. Now this is a very expensive technique, and there are very few of these machines around, and it's being used increasingly in cancer care. And we've got one of these machines in Edmonton, and it's at the Cross Hospital. And I'll describe how it works in a minute. And it requires the use of radioactive isotopes. And you have to have an isotope that emits a positron, and that's why it's called positron emission tomography. And a positron, for those of you who know physics, is the opposite to an electron. It's a positive, it's got the same mass as an electron, but it's got an opposite charge. The electron's got a negative charge. A positron, by the name, has a positive charge. Now, positron and electrons are antiparticles, so when they meet, they annihilate each other and generate energy. And they generate energy in the form of what are called photons, which are particles of electromagnetic energy. And so, what happens is that they inject this radioactive compound that emits the positrons. And the positron, so now these positrons are circulating around in the blood, And every now and again, of course, those positrons will come meet an electron somewhere in the brain, let's say. And when it does, there's a gamma ray sort of shot out in both directions. And you have this huge bunch of detectors around the head that can detect the electromagnetic radiation, which is the gamma ray. and so you do, and of course protons are meeting, positrons are meeting electrons all over the place, millions and millions of things, and you collect millions and millions of these signals around these detectors. And again, using a lot of computational work, you can build up an image of where there's the biggest concentration of positrons, and usually that's in active brain areas because there's more blood flow, so there'll be more positrons being going to that part of the brain. And so this is just an example of seeing a word, listening to a word, speaking words, and you can see with these different tasks, different parts of the brain light up. But that's just like fMRI, and in fact fMRI will do that for you. The huge advantage of positron emission tomography is that you can look at the metabolism of the brain, which you can't do with fMRI. You can say, you can have these radioactive compounds that will enter metabolic pathways within the brain and get localized in a certain chemical environment. And so you can study how this chemical environment is changing over time, or whether it's abnormal in an individual. So now, where do we get these radioactive compounds from? Well, the half-life of these radioactive compounds is only a few hours. So they have to be made on site. You have to have a cyclotron, which is a machine, to make these radioactive compounds. And some of you may have seen, if you go down Belgravia Road, and on the Balmoral curling club up there on the left as you go down the road, they're building a big new building out the back. It's covered in blue tarpaulins right now. You might have noticed it if you go down Belgravia. That is going to be a new cyclotron for the PET scanner at the Cross Cancer Institute. And so what they're going to do is, let's say a person, they know they've got a patient coming in the morning to have one of these scans, because you could localize cancer very nicely with this technique in different parts of the body. So they'll make the radioactive compound at, let's say, 9 o'clock in the morning. They'll rush it across to the Cross Cancer Institute, inject it into the patient and do the scan. And the half-life of this compound is a few hours, 1 to 2, 3, it depends on the compound. And they're even making it for Calgary. So if you're making it for Calgary, what you have to do is you've got to whip it across to the airport, put it on an aeroplane, fly it down to Calgary, whip it from the airport in Calgary to the PET scanner, and they can do this now. So this facility that they're making down here on Belgravia Road is making these isotopes for positron emission tomography. Just an aside that you might be interested, because I wondered what that, I didn't know that area, and I wondered, oh, this is good, because it's sort of foundation. The foundations of that place, a concrete wall 10 feet wide. 10 feet, that's pretty big, that's from here to the wall. And of course that's to stop external radiation. If you're playing curling there, you don't want to be bombarded. You want to be bombarded with positrons there. Anyway, so now that's not going to be on the exam. So, okay, so positron emission tomography. There is another sort of related technique. There's a mistake here. There should be single photon. I just noticed it this morning when I was looking over the notes here. There's a photo in your notes, just photon. There's another related technique called SPEC, where rather than getting this annihilation of positrons and electrons, they just inject a gamma ray into an isotope, and they pick up the gamma rays in the same way as they've done here. The thing with SPEC, it can certainly give you information, but it's not nearly as precise in terms of localization. So where's it used? Well, as I say, the huge advantage of PET is that you can look at metabolic pathways can be studied with this technique. And here's the case where they put fluorinated dopa. Now dopa is a precursor to dopamine. And so it enters the metabolic pathway that's synthesizing dopamine, which is a transmitter in the brain. And so now you've got this fluorinated positron-emitting substance that goes to where the cells that use dopamine as a transmitter. Now some of you may know, and you'll certainly learn in this course, that one of the problems with Parkinson's disease is that there's a loss of cells that use dopamine. And so you'd expect then that you'd see less of this fluorinated dopamine in a Parkinson's patient. That's exactly what's shown here. So here's the PET scan for a normal individual. This is looking at part of the basal ganglia, which Peter talked about earlier. And here's a Parkinson's patient. You can see that there's far less signal there in a Parkinson's patient, and that's related to the fact that they have far fewer dopaminergic containing neurons. And so this fluorinated dopa can't enter anything, there's nothing there to enter. So it just gets washed around. Finally, the last scanning technique I wanted to mention is angiography. This is used in many hospitals. And this is just a sort of X-ray technique for looking at very fine the structure of the blood vessels in the brain and other parts of the body as well, for that matter. And so basically what it is, you inject a X-ray opaque substance, the substance that won't allow X-rays to pass through it, and then you just take an X-ray. And so you can see, you can image the blood vessels very nicely with this technique. And here's the case of, so they put the catheter in, here's the catheter going in here to inject the dye into the arteries. And this is a patient that had a blood clot. He had a stroke where a blood clot was clogging up the basilar artery up here. And what you don't see much network of blood vessels at all here. Then they've injected a compound, and again, you're going to learn a lot about this when you do the lectures on stroke, called TPA, tissue plasminogen activator, TPA. And this is what, you have this type of stroke that clogs up a blood vessel in the brain, and you get into the hospital within 3 hours, they'll inject this stuff, and what it does is dissolve the clot. And so this TPA was then given to this individual, and now you can see the clot's been dissolved, and you can see this whole network of blood vessels that have been opened up because the clot's gone away. So that's just an example of imaging the blood vessels and seeing the response to this drug TPA. You'll learn much more about this when we do the lecture on stroke later on. I'm just giving you an overview. So that's imaging. Any questions on any of those imaging techniques? Move on. Okay, go. Let's move on. Now, recording methods. There's a whole bunch of recording methods. And basically what you're trying to do is to use these recording methods to monitor the activity of nerve cells in the brain. And by looking at these patterns of activity, you can tell is the activity normal or abnormal, and so on. And you can use it for basic research as well. So again, this is just a list. I'll start off each of these sections with a list, and then I'll talk about each one individually. So electroencephalography. This is an old and very common technique. Might be used in sleep studies. Let's say you've got a patient that's got really bad sleep disorders, or suspect they might have narcolepsy or something like that. Then they might go to a sleep clinic and have an electroencephalography study where they put these electrodes on the skull and get them to sleep, and with certain sleep disorders you'll see very abnormal patterns of electrical activity. So in electroencephalography, EEG, you can place, well, a large number of electrodes. You don't have to have as many as this necessarily, but quite a few. And then you record these tiny little electrical signals, these sort of just wiggles, at the different electrode places, points. And this is just showing at the bottom. There's a chart recording. And the signals are just in the microvolt range. That's a millionth. A microvolt is a millionth of a volt. So you can see that this would be plus or minus 20 microvolts, so they're tiny signals. But nevertheless, they convey a lot of information, and you can tell a lot about what's going on. Now, the way that EEGs are generated, well, they're generated way down in the neural tissue, underneath the skull. Here's the bone of the skull and the skin, and then there's spaces here, and so on, the dura. So really, the recordings you're getting from the brain are actually a long way from where the actual signals are generated. And that means you get a very low spatial resolution. In other words, you can't really say exactly where these signals are being generated. There are computer methods that you can localize it a bit better, but in general, it's a pretty poor spatial resolution. Nevertheless, the signals are robust, and they have certain patterns to them. But one of the big advantages is they've got, on the other hand, a high temporal resolution. Now, temporal just means in time. So you can really determine how things change in time with this technique, which is nice. So it's high temporal resolution and a poor spatial resolution. And the way these signals are generated is that when you have depolarization of cells in the brain, you get currents flowing in the extracellular space. And so you'll generate essentially what are called dipoles, that is negative sinks, the sources, and positive sources and negative sinks, and these currents flow around and they spread out, in fact, right up to the skull, and you can detect them right here at the skull. And that's why they're so tiny, because these are fairly small signals to start with, and then they've got to see sort of across all this tissue as well. So they decline in amplitude a lot as they go across. Okay. Now here are some of the brain rhythms I talked about, and they're given these names: alpha, beta, gamma, delta, theta, and there are different frequency ranges for each one. And again, when you do sleep, when epilepsy stuff later on, we'll be learning more about these different rhythms. And I think you should sort of know this in general. But what's been interesting is that these different rhythms are associated with different states. So in deep sleep, for example, when you're sound asleep and not dreaming, the delta wave, very slow wave, about 2 hertz, they often call it slow wave sleep, comes along. And when you're aroused and awake, you have 20 hertz. Alpha frequency, if you're just resting with your eyes closed, you'll have about a 10 hertz frequency, and so on. And so scientists use these rhythms a lot to investigate brain function, especially in psychology departments. A lot of psychologists use this technique to study human cognitive processing. Now, an extension of EEG stuff is what's called intracranial electroencephalography. And I told you that these signals have got very poor spatial resolution. Now, to improve the spatial resolution, what's sometimes done these days is to open up the skull and take a big chunk of bone off the skull, expose the brain, and put the recording electrodes directly on top of the brain. That's why it's called intracranial. Intracranial, because it's inside the cranium. And here's an X-ray of a person who's had an array of these electrodes. Each one of these white dots here is a recording electrode. And this is what the neurologist or neurosurgeon, it's usually done by neurosurgeons, they would see when they look. Here's the brain exposed, and here's an array of these electrodes all on the brain. Now, why would a neurosurgeon want to implant something like that in the brain? Well, it's to tell them which parts of the brain are normal or abnormal. Because what a neurosurgeon is going to do is to go in there and scoop out part of that brain that's not working. And the reason they're scooping it out is to try and help a person with epilepsy. Epilepsy is an uncontrolled electrical activity of part of the brain. And it's often produced by a focal point in the brain, a little bit of bad tissue that starts irritating other neurons, and that spreads. And so you have abnormal. So what the neurosurgeons are trying to do is to try and take out that bit of bad tissue that's starting the irritation, so to speak. And so what they're looking for with this array of electrodes are the parts of the brain that have abnormal electrical activity, because that's the ones they'll go for and scoop out in their neurosurgery. And this is just, again, recording from many different combinations of these electrodes. And there's some abnormal activity in a couple of, 3 places in this array here, and it's shown by these red stars here. And you're going to get a lecture later on by Matt Wheatley. He's a neurosurgeon here, and he does this sort of procedure on many patients here at this university hospital. And it even goes further now. What they can now do is to actually insert electrodes array into the neural tissue itself. It's like a little harpoon with a whole bunch of electrodes on it, and they shove that harpoon into the brain to record electrical activity, not just on the surface, but deeper down in the cortex. And this is, he'll describe this to you and how he does it, and he'll show you videos of him doing these operations and things like that. You'll see that later on. So that's an important surgical technique, and we've done more so. Magnetoencephalography. This is just a research tool. There's not one of these. There is not a machine like this in Edmonton. The closest one is at UBC in Vancouver. But the great thing about it's a bit like, well, when cells become active, they generate electric fields. And with every electric field, there's an associated magnetic field. That's just a basic law of physics. So the electromagnetic radiation is if you have an electric field, you have an associated magnetic field. So you can either record the electric field, which we do with electrical devices, or you can record the magnetic field. But to record magnetic fields is very difficult and expensive. But nevertheless, it can be done. So here's the subject with his head into a special place here, and there's all sorts of contraptions to actually detect these magnetic fields in his head. This thing is about 3 stories high. You can see the bottom part of it here, but it's a colossal machine, enormously expensive. But the great advantages of this for a research equipment is got extremely fast temporal resolution. And furthermore, which I haven't got here, you can sometimes see deeper down into the tissue than you can with other techniques. The disadvantage is that it's got better spatial resolution than EEG, but it's still not great. But it's often used, if you're interested in the time course of events in the brain related to a function, then this is often a good technique to use. Yes?
Why can't you use that instead of the intracranial
Well, it's part of it is the enormous expense, and secondly, it wouldn't be as spatially as good as intracranial EEG. The intracranial is pretty precise. It's only the bit underneath the electrodes that you're recording, and not the whole. See, you've got all those electrodes where each one is very highly localized on the brain. And it's the expenses and other things. Okay, and finally, this is the last one. Single unit recording. This, in animal studies, this is one of the most prominent techniques that's used, and occasionally in humans it can be done as well. Less so, but usually only for research studies, although it can be used in clinical medicine occasionally, and I'll describe that. So why it's called single unit first off. It's single unit because we're going to record the activity of single nerve cells. Just one nerve cell. And this is pretty good, amazing because you've got billions of nerve cells in your brain. And with this technique, you can just record from one of those billions. But you need a special electrode, and it's placed very close to the cell body. Not inside it, but just close to it. It's outside, but close. And when nerve cells become active, they generate electrical potentials that look like this when you record outside them. And they're quite small. Look at the number here. This is important. It's just 0.1 millivolt. That's a tiny amount compared to the potential across the cell membrane, which is about 100 millivolts. And it's got this diphasic shape here, usually going negative first. Well, you can look at a single action potentials, or you could look at a train of action potentials. And rather than recording all this, what often is done is we just record the time that each one of these spikes occurs, and label that just with a dot, or in this case a little rectangle. Now, what you can now do is, let's say you're picking up, so you can have one trial. It might be giving a person a stimulus, a visual stimulus, let's say. And so each one of these little dots here is an action potential. And then here's the stimulus. And you see the activity of the cell increases for a little while and then dies down again. So that could be the first trial. And then the next line would be the next trial. Third trial, fourth trial, and so on. So there's probably, 20 trials here probably. So this is called a raster plot. And it's a way of monitoring the overall activity of that one cell. You can see it's variable from stimulus to giving exactly the same stimulus, but there's variability in the activity of that nerve cell. But you can get the average activity just by summing up the number of events that occur at different points, and you'll get this post-stimulus time histogram here. So what you can see here is that after the stimulus, this one cell becomes quite active for a short period of time, and then its activity dies down after that. So you can get a very accurate picture of what individual nerve cells do in relation to a certain stimulus. Or it could be in relationship to a movement if the subject makes a movement. So that's single unit recording. And It has been, this is largely done in animal work. It's a very, very common technique in animal research. And in humans, these single electrodes have been implanted into the human brain. And here's an example of an electrode into the hippocampus of a human. And this we don't do it to everybody. I mean, we wouldn't take you folks, any of you folks. This is done, again, for a patient that's suffering from epilepsy. And they're using this electrode for the same reason that I talked about before. They're trying to identify the part of the brain, part of the hippocampus in this case, that's functioning abnormally. And so they've got this electrode in here, and they move it around a bit, and so they can find what's the normal tissue and what's the abnormal tissue. And they're going, and the neurosurgeon goes in subsequently and removes the abnormal tissue. So this is why these electrodes are implanted into human beings. But while they're implanted, you can actually get information about the normal functioning of nerve cells. And I'll just give you one example of that, which is quite interesting that you can do this. So this is recording done in the hippocampus when you're showing the individual different categories of visual stimuli. And so there's the category of animals, a leopard, a rabbit, and a bear, foods, and buildings. And there are many other categories as well, faces and so on. And what they discovered in this study, which was done a little over 10 years ago now, is in certain regions of the hippocampus, the cells are highly specific, their responses are highly specific to a certain category of stimuli. And so here are these post-stimulus time histograms now. It's a bit hard for you at the back to read this, I'm sure. You can see it in the notes. This is just to, let's say, faces. When they showed the subject faces, this cell didn't fire at all. There's no response. But when they showed it any animals, this cell fired very nicely. It gave this big peak here. So this cell was sort of responded to the category of animals. Doesn't matter which animal it was, just animals. And here's another cell that was responsive to faces. So with animals, that's this set of this histogram over here. You can see there's no response. Time 0 is the time when the stimulus was presented. And you can see there's no response. But when they showed this, the subject either a face drawing or a picture of a famous face, this cell fired. And so you've got cells in this part of the brain that respond specifically to visual stimuli containing faces. So that's how it can be used for basic research as well as clinical research. Finally, for the recording, one of the very interesting and exciting developments in rehabilitation of people that have had stroke or have very advanced motor neuron disease is to try and get them to directly control robots by just thinking about things. In other words, getting signals from the brain and using those signals from the brain to control some device. It could be turning on a light, or it could be also anything you can think of. And these are called brain-computer interfaces. So what you want to do is to couple up the brain here, with some computing device that the subject can control. And so what's being done now, and again, this is just an experimental procedure. It's not something that's common, but it's, you know, in the future, another 10 years, this may be used in more cases, is that they implant a little electrode array. There's something like 100 electrodes here, and they push it into the cortex. And on the left here is a picture of this little recording array. You can see it's quite tiny in relationship to the whole size of the brain. But this is actually implanted into the motor cortex of an individual. And the motor cortex, remember, is the part of the brain that sends the commands down to the motor nerve cells in the spinal cord to produce movements. And so what they're trying to do here is to get the subject to control the brain activity in the motor cortex, and you take the signals from this device out to a computer to control some device. Well, here's the subject. This was the first one that was implanted in a lab in the States about 6 years ago, I think it was. And this guy is a quadriplegic patient. He's got no voluntary movement, he's unable to move his arms or his legs and so on, but he can see things and he can talk and he can think. And they've got, here's the recording device in his, fixed to his skull, and here all the electrodes, the information of the electrodes are led out to this place, and here goes into the computer from here. Anyway, this chap after a little bit of practice, just by thinking, could move a cursor around on this computer screen here. So he thinks, well, I want to move that cursor to the left. So he's just sitting here, thinking about that, and sure enough, the cursor goes to the left. And you move it down, it goes down, and so on. And so this is, there have been some remarkable things. Go to YouTube, for example. Just go to YouTube and type in brain-computer interface. And you'll see some work that's been done in monkeys, which is really quite remarkable, where they've got these brain-computer interfaces planted into the animals, and the animal, just by thinking, the animal's not moving its arms at all, it's just sitting there, and just by thinking, it's able to control a robot arm that comes out, grabs a piece of food, and then brings the food into its mouth. And that's all done by this monkey generating the appropriate signals in the motor part of its brain that are then detected by these rays and allow the animal to control the robot. So just go to YouTube tonight and have a look at that. Just type in brain-computer interface and a couple of dozen things. Anyway, so this is recording. Remember what the topic is now? We're talking about recording. And this is one place recordings are used. But not in the day-to-day bread and butter rehabilitation of patients. This is at the moment, this is an experimental technique with a lot of interest, and who knows where it will end up in another 10 or 15 years. Finally, I guess, I keep saying finally because I keep forgetting there's so many of these things. We can actually also record from peripheral nerves with a single unit of activity from nerves and so on. And this sometimes can be used to detect what's going on, but it's often a research tool as well. So again, you have a very fine electrode that's placed inside the nerve, into the tissue, not inside a single nerve, inside the nerve bundle. So it's actually outside the axon. But you can pick up single spikes, again recording extracellularly, and then you can stimulate the skin and you can study the properties of the individual receptors. And you can use this for measuring conduction velocity and things like that. Again, this is not used very much clinically, but it's certainly an important technique from basic research point of view. Electromyography, though, is used clinically, and this is quite an important technique. And this is a method for recording the activity from muscles. Now, remember back to your basic physiology. When muscles become active, they generate action potentials, and those action potentials conduct along the muscle fibers, depolarize the cells, and release calcium into the muscle, and that's what produces the contraction of the muscle. Well, that electrical activity in the muscles can be really easily recorded. You just need a couple of electrodes, and you just put them on top of the muscle, and when the muscle contracts, you'll detect the signal. So here's just a picture of what it looks like. Here are the recording electrodes on top of the muscles, the biceps and the triceps, fed into an amplifier. And this is what a raw EMG would look like, electromyogram. It looks a pretty messy record. But this, remember, there are many different muscle fibers and many different motor units that become active. And so you're recording the summed activity of many, many different motor units. And each one of those spikes is from a different motor unit, or maybe from the same couple from the same, but the Wybert's medicine is many of them. And this is what I'm talking about. Remember, a motor unit is the motor neuron, and all the muscle fibers of it. That's the smallest unit of contraction in the muscle. The motor neuron plus the muscle fibers of it. And you have different motor units. So here's 2 motor units. And in skeletal muscles of humans, individual nerves each muscle fiber usually only receives input from a single motor neuron. There's not polyneuronal innervation, as it's called. So when you record the EMG, so here's a case where you can see some large spikes in the EMG. Probably this large spike is just from one of these motor units becoming active. And then these other smaller spikes would be from other motor units and so on. Now, there are certain neurological disorders in which the motor neurons and muscles get mucked up for one reason or another, genetic reasons or environmental reasons. And neurologists, by looking closely at these EMGs, can often get a sense, well, what's wrong with the muscle or the neuromuscular transmission and so on. So it is used clinically to analyse muscle disorders and nerve disorder, peripheral nerve disorders as well. Okay, so that's the recording techniques. I've just got this last bit to go. Any questions on that? Okie doke. So let's move on to the last section, which is stimulating methods. Not only do you want to record what goes on, but it's often you want to actually evoke things and make things change by stimulating this neural tissue. And you can either do this by electrical stimulation of peripheral nerves. Deep brain stimulation is also electrical stimulation, but it's done deep in the brain, so these two really should go. This deep brain stimulation should come under the heading of electrical nerve stimulation. And then there's magnetic stimulation, TMS, which is being used increasingly. So they're the three sort of major topics I want to talk about. Now, electrical stimulation, again, this is done in neurology because very often people have peripheral neuropathies. Peripheral neuropathy is something wrong with the conduction in nerves. And the clinician wants to find out, well, is there, first of all, a problem? Are the nerves normal or are they not normal? And one way of doing that is to measure the conduction velocity in the nerves. And so that's pretty easy to do, actually. You can electrically stimulate, let's imagine a nerve coming down the arm here and going out to these muscles here. Or you can electrically stimulate the nerve at this point, and then you just figure out, well, how long does it take to reach the hand, the activity? And you can measure the response by the EMG. So you have an EMG recording system here on the hand, and you electrically stimulate here. And you can imagine then that the time it takes to get from the electric point where you stimulate to the point in the hand is related to the conduction velocity. In other words, that time will be shorter if the conduction velocity is high. And so this is what is done. And so you combine electrical stimulation with EMG recording to work out the conduction velocity. The typical motor nerve conduction velocity, this is a number you should sort of keep in mind, it's just for reference, it's about 60 meters a second. So let's say a neurologist who has his patient who makes these recordings and he sees, oh, the conduction velocity is down 30, 20, 30 meters a second. Something's wrong here. We better do another investigation. It might be multiple sclerosis, for example. That's a disease that influences conduction along the nerve. It might be something else. It might be a viral infection of the nerve. A whole bunch of possibilities that you work up. But by just measuring this conduction velocity and seeing that it's changed in the peripheral nerve gives you a clue on what's happening. So, deep brain stimulation. Now, you're going to see when we talk about Parkinson's disease later on, you'll see some videos of patients that are receiving this. And it's the most remarkable thing that you can, what is done is you implant a stimulating electrode deep down into the basal ganglia or thalamus. Remember those parts of the brain, previous lectures. And depending on where you target it, you do it for different reasons. You might want to stop, let's say, tremor. Some patients have terrible tremor, they just can't stop. And there are certain sites that you can electrically stimulate to stop that tremor. Or the person can't sort of initiate a motor action. And there's another site that you might stimulate to help them initiate motor action. So you'll learn all that. I'm not going to go through that. You'll learn all that when you do the lecture on Parkinson's later on. But I just want to talk about the technique. So the technique is that you put this special electrode and the end of it ends up into one of these nuclei deep down in the brain. That's why it's called deep brain stimulation, because you're aiming for nuclei deep in the brain. And here's a picture of a patient undergoing this, getting the electrode implanted. So there's been a hole bored in the head here. Opened up so the brain is exposed. The electrode then is pushed down into the brain. And there are certain ways of telling exactly where the electrode is, because you obviously don't want to put it in the wrong place. And it's quite a delicate operation to get that electrode in exactly the right place, because some of these nuclei are just a few millimeters in diameter. So you're trying to aim down, you can't see anything, at least directly, and you're aiming this electrode down in the brain, you've got to get it positioned within a couple of millimeters of the right place. Well, of course, there's a lot of X-ray things that they can do and so on to help them after a while. But this is often done with the patient awake, because the brain has no pain receptors. And so if you just locally anaesthetize around where you're going to take off the piece of bone in the skull, you can then, once that's anaesthetized, then you can push the electrode into the brain, and the patient does not have to be asleep. And this is an advantage because this can sometimes help them localize the electrode, because they might stimulate And they know that if they've got in the right place, the patient will not be able to lift their arm, or they may be able to lift their arm. In other words, certain motor actions may be changed depending on where they are with their electrode. So it gives them a clue on exactly where they are in the brain by the patient making voluntary movements. They might just grasp things, and so on. So that's what this picture on the right here is showing you, is that they probably they've got the electrode where they think is the right place. They then stimulate and ask the patient to lift their arm. Now, if you couldn't lift his arm, they might say, oh, doctor, you're not in the right place. It's got to be able to lift his arm if you're in the right place. Or might be the opposite, it doesn't matter. You get the idea. So the current uses, Parkinson's disease is certainly one. Dystonia. Dystonia is abnormal movements and sort of paralysis of not being able to move properly. And it can be quite focal. Musicians often get it in their fingers when they're moving. They can't move their fingers independently. They might move, the whole hand might move and so on. You can get speech dystonia. So it's sort of abnormal coordination of muscles. And sometimes deep brain stimulation can help there. But it has to be very severe before they do this. And again, I think you'll see Matt Wheaton's got a video of a young boy who's got severe dystonia throughout his whole body. And this deep brain stimulation had a remarkable effect for him. Really, really helped him able to move. More recently, severe depression is being used for. There are some patients that get so depressed and so on that the drugs don't help them. You can give them all the antidepressants and so on, and it just doesn't help them. Sometimes they consider what's called psychosurgery or neurosurgery. They might take out a part of a special part of the cortex to try and help them. And more recently, they're trying to do electrical stimulation in some of these patients. It's not common, but it's being looked at, and it'll probably come along more and more as time goes on. So that's deep brain stimulation. Finally, and this is transcranial magnetic stimulation. Now this is a device that generates a very high magnetic field with this sort of this figure 8 contraption here. And this, when the magnetic field flows through the neural tissue of the brain, it actually activates, it can activate or inhibit depending on how you put the pattern of activity in this device. But you see the magnetic fields go into the brain and impulses, so they pulse, pop, 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 pop. And you can either activate neurons here, stimulate neurons, or if you do it repetitively, you can actually transiently inhibit neurons, so that shut them down for a little bit of time. And this is largely research tool, although a lot of research is going on to see if it can be helpful for different psychiatric disorders and so on. So a person's depressed, for example, with this help. Now an example of where it's been used is mapping the motor cortex. Now we know, again from Peter's work, there's a sort of homunculus on the motor cortex with the face region, the visual representation, hand region, and so on. And if you give TMS on the cortex, then you can activate the descending fibers from the motor cortex that go down, let's say, the hand muscle. And so what you can do is put an EMG recording electrodes on hand muscle, and you can put the magnetic pulses on the skull, or through the skull, and you send in the pulses, and what you'll see is you might see the hand twitch like this. Every time you go to pulse, the hand will twitch. And so you can sort of then map the motor cortex in an individual, because you could move the stimulating electrode, the magnet, and rather than getting a little finger twitching like this, let's say, you might get the whole wrist going. And you move a little bit more, you might get the whole arm going. And so you can actually just map out the motor cortex using this technique with single pulses. So you're activating different regions of this using this. And so this is a combination now of electromyogram recording and transcranial magnetic stimulation. And that's sort of for research purposes. Now, people have a stroke, and often they want to see, well, how's the brain being modified as they're recovering from the stroke? Well, you can take this and do it on subsequent times as the patient, let's say, going through rehab. A stroke patient is having rehab, and they're getting better. They're able to manipulate things better and grab things better. And you can ask the question, well, is that due to the motor cortex being reorganized and changing its properties? And the way you can tell that is by doing something like this, and that's been done, in fact. And you do see, as people rehab after a stroke, you'll get modification of these maps in the brain. And those modification of maps are related to their improved function during rehab. And I think the final thing is just a uses of TMS. Single pulse TMS is what I just talked to you, where you're just mapping things out. It can be used for mapping changes in cortical excitability and behaviour, and mapping motor cortex maps after stroke and during rehab. And then there's repetitive TMS, and this has been tried in clinical application. And repetitive TMS, and this is when you give a series of pulses, pop, 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 pop. Often, rather than exciting neuron, initially there's excitation, but over time it suppresses, for what reasons we don't fully understand. It tends to turn off the tissue. It's thought to be because it's activating inhibitory interneurons in the cortex, and that's suppressing activity in the cortex. And so you can actually sort of transiently remove certain groups of neurons from brain function and see how that affects behavior. And so the idea is if you have a hyperactive set of cells or something, you might be able to use repetitive TMS to tone down the activity in those cells and get better improvement in behavior. And some of the places where it's been looked at is how to enhance functional calcifying the stroke, reduction of chronic pain. You'll have electron pain, that's a really important one. Treatment of depression and various other psychiatric conditions, and treatment of movement disorders. But none of these is it being used in a regular clinical way yet. This is something that's on the horizon and you should be aware of. So I think that's it. Oh yes, this is really important because molecular genetics is a technique I've not talked about, but it is really, really coming into its own now. And you'll hear this from Francois later on, how it's been used to look at the genotype of people, and we're trying to relate the genetic background of people to their illness and so on. So you're trying to correlate genetic factors with illness. And this has been, like for example, autism. You'll hear this in autism. Is there a relationship between genetics and autism? Well, one of the tests they do, if a neurologist might do, if they suspect a child that has autism, they might do a genome screen to look for certain genes that have been associated with autism. So genetics is becoming a very powerful technique, and Francois will talk about that a little bit in the next lecture.